Alright, so next we should talk about the oral anti-diabetic drugs. The name only says oral means we can consume it orally. So previously we had seen about the insulin, which is given via subcutaneous route to the max, and whereas regular insulin is given via intravenous route. But these anti-diabetic drugs are taken orally, so these are anti, that is against diabetes mellitus. So we have got four classes of drugs, as you can see. The first class is the drugs that enhance insulin action. So basically these drugs will increase the insulin secretion. Next drug is drugs that overcome insulin resistance. Third one is retard carbohydrate absorption. So nothing to do with insulin over here. They are just inhibiting the carbohydrate absorption. And lastly, we have got certain miscellaneous drugs. So we shall check out all these classes one by one. So coming to the first class, that is the drugs that enhance insulin action. In this also we have got two subclasses. First one is KATP channel blockers. So KATP, so you people know that is ATP sensitive potassium channel blocker. And again in this class we have got two classes of drug again. First one is sulfonylureas and another one is meglitinide, also known as phenylalanine analogues. Okay, so these both are the drugs that what it will do, it will cause blockage of potassium ATP. Okay, so first of all we'll check out what happens where it is potassium ATP, and then we'll check out first of all about sulfonylureas and then the meglitinide. So for knowing about the potassium channel, or you can say rather more specifically ATP sensitive potassium channel, which again we shall check out the structure of your beta cell of the pancreatic Langerhans. So suppose this is a beta cell, and you know I have drawn it previously also, and again I am drawing. First of all, it consists of granules consisting of insulin. Yes. Next, it have got a ATP sensitive potassium channel. Suppose this is the area where ATP will come and bind. Okay, this is KATP. Okay, next thing that it has is a calcium channel. Another thing is it has the incretin receptors, that is a G protein couple receptor 1, 2, 3, 4, 5, 6 and 7, along with its alpha, beta and gamma subunit, and here will be your arenylyl cyclase effector. Okay, now what we are talking about is these are the class of cell that will cause blockage of the KATP, that is ATP sensitive potassium channel. So first of all is sulfonylurea, and the examples are tolbutamide, glibenclamide, glyburide, glyclazide and glimepiride. Okay, so what these sulfonylureas will do is they will bind with the sulfonylurea receptor. Now the another question is where exactly is this sulfonylurea receptor present? So the sulfonylurea receptor is basically present on this potassium channel itself. Okay, so this is your SUR. SUR is the sulfonylurea receptor. So when these sulfonylureas such as your tolbutamide, glibenclamide, glimepiride, when you consume it, so it will go and bind with the sulfonylurea receptor. After binding of these sulfonylureas to the sulfonylurea receptor, what will happen? Yes, what it will do? It will block the KATP channel. Okay, so this KATP channel will be blocked. Block means they will be closed. Now what will happen when this potassium, that is ATP sensitive potassium channel of the beta cells will be closing? Yes, what will happen? It will first lead to, yes, partial depolarization, isn't it? Partial depolarization. Next, in response to partial depolarization, what will happen? There will be influx of calcium ion. Okay, so influx of calcium ion means what these calcium ions will be doing? Yes, we have got two important proteins. One protein is present over here, that is the vesicular protein, and another protein is present over here, the membrane protein. So this membrane protein, it will be fusing with the vesicular protein, and what will happen, all this vesicular membrane and the this vesicular membrane and the plasma membrane both will be fused up and they will dissolve. Okay, so there will be a hole produced and there will be a release of insulin via the exocytosis. So this is the mechanism of action of sulfonylureas. So what sulfonylureas will be doing, it will bind with its receptor which is present on the KATP, and binding of which will cause closure of this channel, because of which partial depolarization occurs first of all, followed by partial depolarization there will be influx of calcium ion, and this calcium ion will cause fusion of the vesicular protein with the membrane protein, and both the membranes will dissolve itself and there will be gradual release of the insulin. That's it. So this is the mechanism of action of your sulfonylureas. Very simple. Next thing is, the rate of insulin secretion at any glucose concentration is increased. That is, insulin release is provoked even at low concentration of glucose, and thereby risking the production of severe and unpredictable hypoglycemia. Okay, so this is the problem with this sulfonylureas. So you should make sure that you should consume an adequate amount of meal whenever you are consuming sulfonylureas, because even at low concentration of insulin, a huge amount of at a low concentration of glucose also, a huge amount of insulin is being released, so it may risk the problem of your hypoglycemia. Apart from this, we have this sulfonylureas is been placing a lot of drug interaction problem. Drug interaction. So we have got few drugs because of which there will be increased action of your sulfonylureas. Okay, increased SU is for sulfonylurea action. Okay, there are certain drugs along with which when sulfonylurea is being consumed, it will cause an increased or enhanced action of sulfonylureas. Now what these drugs are? First of all, we have got few drugs such as phenylbutazone, sulfenpyrazone, next we have got salicylates, even we have got sulfonamides. So when sulfonylureas is been consumed by any of these drugs, so what these drugs will do, they will displace the sulfonylurea from the plasma protein binding site. So you can say displacement reaction. Displacement reaction will be taking place, so that huge amount of free form of sulfonylurea will be available for producing the action. So this is one of the drug interaction with the sulfonylurea will be facing, because of which there will be increased action of sulfonylureas. Next we have got another set of drugs such as ketoconazole, chloramphenicol, and warfarin, very important, warfarin, and sometimes alcohol intake. So what these things will do, yes, they will inhibit the metabolism or they may inhibit the excretion. Okay, so sulfonylurea when taken along with ketoconazole or chloroform or warfarin, what they will do, they will inhibit the metabolism of sulfonylurea. That means active form of this sulfonylurea will be present for a long period of time in our body, and there will be profound action. Means its action is basically to reduce the glucose level, to bring it to a normal level. But when the active form of sulfonylurea is too much and for a long period of time inside our body, means it may lead to hypoglycemia kind of crisis. Next, we have got another set of drugs such as salicylates and propranolol. So what this two drug will do? Yes, they will be like a synergistic action. Synergism, drug synergism will be taking place, which is also a kind of drug interaction. Okay, so you should avoid taking sulfonylurea with all these drugs, or else it may lead to hypo, that is reduced blood glucose level kind of condition. So this is one kind of drug interaction. Whereas there is also a kind of drug interaction there where because of which there will be reduced sulfonylurea action. So what these drugs are, we shall check out again one by one. So when sulfonylurea is taken along with drug such as phenobarbital, phenytoin, even rifampicin. So all these drugs, when it is consumed along with sulfonylurea, so they are kind of, they induce the metabolism, especially rifampicin, if you people know, cytochrome P450 inducer. So they will induce the metabolism, so that active form of drug is present for very less time, and it may not treat the hyperglycemia as such. So the glucose level of the blood will be remain high only. So when sulfonylurea is consumed along with these drugs, there will be reduced sulfonylurea action. Next, when it is taken along with another set of drugs such as corticosteroids and some diuretics like furosemide, and even along with oral contraceptives. So when sulfonylurea is consumed along with all these drugs, what will happen? Some opposite action has been produced. Or you can say it suppresses the insulin release. Okay, so these are the drug interaction which is faced by your sulfonylureas. Okay, so this is about the sulfonylureas. Next, we'll talk about the meglitinide or phenylalanine analogues. So we have got two examples for this, that is repaglinide and nateglinide. And the mechanism of action of this class of drug is almost similar to that of sulfonylureas. Means they will also interact with the sulfonylurea receptor which is present on the ATP sensitive potassium channel, and it will cause activation of this receptor. And you know, when this receptor gets activated, it will cause closure of this potassium channel. Once this potassium channel is closed, then what will happen? Yes, it will cause partial depolarization. Once partial depolarization occurs, it will cause influx of calcium ion, and what this calcium ion will do, it will dissolve the vesicular protein, or you can say fuse the vesicular protein with the membrane protein. Both the membranes will fuse up, they will dissolve, and there will be release of the insulin. So almost same mechanism of action. So this meglitinide, although it is not a sulfonylurea, but still it will act like a sulfonylurea. Okay, it will interact with the same receptor, that is sulfonylurea receptor. But the different thing is, this meglitinide, it is absorbed rapidly and even it is metabolized rapidly, and therefore it induces very fast onset of action. Fast onset of action. Okay, who? This meglitinide. Okay, this meglitinide have got a very fast duration, fast onset of action, and lasting insulin release. And because of this characteristic, its pattern of use is different from that of sulfonylureas. Okay, so it is this meglitinide. Okay, this meglitinide, since it has got a very fast onset of action, so these meglitinide, they are mainly administered before each major meal to control the postprandial hyperglycemia. The dose should be vomited if a meal is missed. Because of this short lasting action, it may have a lower risk of serious hypoglycemia as such. Okay, so this is about the meglitinide. Okay, and we are done with the this thing, KATP channel blockers. Next, another class of drug that comes up under the heading of enhanced insulin action is the peptidase 4 inhibitors. Okay, and we know about this enzyme. So first of all, checking out the examples of these DPP4 inhibitors, that is sitagliptin, vildagliptin, sexagliptin, tenaligliptin. It's looking like tenali-rama. Okay, tenaligliptin, allogliptin, and linagliptin. Now, what this enzyme will be doing? Yes, we know very well. Again, we'll brush up. We know this is the incretin receptor. IR, I'll write for now. Incretin receptor, and ingredients such as GLP1 and GLP1 and GIP. What these ingredients will do, it will interact with the incretin receptor, and there will be activation of adenylyl cyclase. Cyclic AMP will be formed, and this cyclic AMP will enhance the release of insulin. This thing we knew. And apart from this, we have got what is the role of our enzyme DPP4. What this DPP4 will do, it will inhibit these ingredients. When these ingredients are inhibited, means there won't be activation of this G protein coupled receptor, there won't be activation of adenylyl cyclase, and this conversion of ATP into cyclic AMP, it is also been inhibited, and the activation of means this cyclic AMP induced release of insulin is also been inhibited because of this DPP4. Okay, DPP4 is an inhibitor of these ingredients. So we want such a drug that will inhibit this enzyme only, and that drug is the DPP inhibitors. So what these DPP inhibitors will do, they will inhibit this DPP4 enzyme, because of which we have got huge amount of ingredients. We know ingredients, it is mainly released from the gut whenever you consume the glucose, and what this ingredient will do, it will interact with its receptor. It will cause activation of adenylyl cyclase, because of which cyclic AMP will be produced, and the cyclic AMP, it works just like a calcium ions, that is, it causes fusion of the channel and will cause a release of insulin. And this is how these inhibitors will cause enhance in the insulin action by enhancing the insulin release. Okay, so this was about the first class of our oral anti-diabetic drug, that is enhanced insulin action. First one is KATP channel blocker, and second one was the dipeptidyl peptidase 4 inhibitors. Next, we'll check out the second class of drug, that is the drugs that overcome insulin resistance. And here also we have got again two subclasses in this class. First one is Biguanides, and another one is Thiazolidinediones. So first we'll talk about Biguanides. We have got just one example, that is metformin. Previously we had one more drug in this class, that is fenformin, but fenformin is not been used, it is been withdrawn because of the side effect that it causes a risk of lactic acidosis. So now only metformin is used, and this metformin is totally different from the first class of drug. Okay, the first class was drug, what it did, it will increase the insulin release, but it will it will overcome the insulin resistance, but it will increase the insulin utilization, you can say. And the main advantage of these Biguanides or this class of drug is that it will not produce hypoglycemia, but it will produce euglycemia. A euglycemic condition will be there, and for this class of drug to produce its action, a little amount of insulin is required. Therefore, you can say this class of drug can be used in the treatment of type 2 diabetes mellitus, but it is totally ineffective in case of type 1 diabetes mellitus, because in type 1 there is literally no beta cells available, and when there is no beta cells available means there is no insulin as well. Okay, so for producing this metformin, for producing its action, it requires a little amount of insulin to be present. Okay, now how it produces its action is, it has got mainly three mechanisms of action. We shall check out now. Next, we shall check out the mechanism of action of this metformin. Though it is not clearly understood, but we have got some kind of information that what metformin will do is, it mainly causes activation of AMP kinase. Activation of AMP kinase. Now, because of activation of AMP kinase, what things will be happening? First of all is, it will suppress gluconeogenesis, and when gluconeogenesis is suppressed, it will cause inhibition of glucose output from liver. So this is the first mechanism. So what has been happened? Suppression of gluconeogenesis. Gluconeogenesis means synthesis of glucose from a non-glucose or non-carbohydrate source, like proteins are being converted into glucose or fat has been converted into glucose. That is gluconeogenesis. But when AMP kinase has been activated, it will suppress the gluconeogenesis. And you know, gluconeogenesis mainly takes place in your liver, so it will inhibit gluconeogenesis. When there is no new glucose is being synthesized in the liver, then there is no question of release of glucose or glucose output from the liver. So no new glucose is being synthesized because of this metformin. This is the first mechanism. Second mechanism, what is the second mechanism? Suppose this is your skeletal muscle, and suppose this is your fat cells or your adipose tissue, more better way. So what happens is, the role of insulin. What is the role of insulin? The role of insulin is to convert glucose into glycogen, and this glycogen is then stored into your skeletal muscle. Okay, next, insulin have also got the role to convert glucose and store it into your fatty cell, or you can say lipogenesis should be taking place. So because of metformin, this role of insulin is been taken up by the insulin. That's it. So basically what metformin do, it increases the insulin mediated glucose uptake and disposal in skeletal muscle and fats. So there will be increased glycogen storage and there will be increased lipogenesis in the adipose tissue. Okay, so this is the second mechanism. And next, coming to the third mechanism of your metformin or your Meglitinide, you can say. The third mechanism is, it interferes with the mitochondrial respiratory chain. Interferes with the mitochondrial respiratory chain. And you might be knowing what is the mitochondrial respiratory chain. Yes, mitochondria, the powerhouse of our cell. It is involved in the synthesis of ATP. So what happens, you know what it does? This Biguanides, when it interferes with the mitochondrial respiratory chain, and then what it will cause? It will promote the glucose utilization through the aerobic respiration. Okay, so this is the third mechanism of action of your Biguanides. Okay, so next drug in our list is the thiazolidinedione, and we have got just one example, that is pioglitazone. Previously we had one more drug in this class, that is rosiglitazone, but it is no more used nowadays because it causes adverse effects like congestive heart failure, myocardial infarction, angina, and even death. Okay, so only pioglitazone is used right now. Even because of some cases, even this pioglitazone, it was banned because it showed that it may produce carcinoma of urinary bladder, and therefore it was banned in India in June 2013. However, after 2 months the ban was been removed, but this particular drug had a warning that this pioglitazone, it should never be used as a first line drug. Okay, so this was some intro regarding this pioglitazone. Next, quickly we shall check out the mechanism of action of pioglitazone. So, this pioglitazone mainly acts on a receptor, and where this receptor is present is, suppose this is your skeletal muscles, this is your skeletal muscle, and this is your adipose tissue. So on these two structures we have got a receptor. Suppose this is a receptor, and the name of this receptor is peroxisome proliferator activated receptor gamma. Okay, abbreviated as PPAR gamma. Okay, this is the name of the receptor. Okay, and where this receptor is present, it is present on the skeletal muscle as well as on the adipose tissues. Now what happened when our drug pioglitazone interact with this PPAR receptor means, suppose this is our drug pioglitazone and it interacted with this PPAR gamma receptor which is present on skeletal muscle as well as on the adipose tissue. So what will happen, it will mainly affect the nucleus of these both tissues, so that a gene is being produced, a gene is synthesized. Gene is synthesized means transcription will be taking place, some kind of mRNA will be produced, some kind of gene is produced. And what kind of gene is this? This is a kind of insulin responsive genes, insulin responsive gene. All right, so insulin responsive gene is being produced, is being synthesized, so mRNA is taking place, means transcription is being taking place. And transcription is usually followed by, or you can say always it is followed by translation, some kind of protein synthesis. So increased amount of transporter is being produced in both these tissues. And what kind of transporter is this? This is the GLUT4 transporter. So GLUT4 transporter, it is a kind of transporter that will transport the glucose, and this transporter is basically present on the skeletal muscle and the adipose tissue. So what will happen, whatever glucose is there, it is transported via GLUT4 into both these tissues, that is skeletal muscle as well as in your adipose tissue. Okay, so glucose, when it is transported to skeletal muscle means obviously glucose is being converted into glycogen, and when it is transported to adipose tissue means obviously lipogenesis will be taking place. Okay, so this is the mechanism of action. And in addition to this activation of this receptor, what else it will do means it will reduce the hepatic gluconeogenesis. It is another action, it is reducing the hepatic gluconeogenesis, means no new glucose is being synthesized. Gluconeogenesis means synthesis of glucose from non-carbohydrate source. So activation of this receptor will also inhibit the hepatic gluconeogenesis, plus it will increase the uptake of the glucose inside the skeletal muscle as well as inside the adipose tissue. Okay, so basically here also we require a little amount of insulin. Okay, without insulin this work cannot be done. So both the class of this drug, that is Biguanides as well as Thiazolidinediones, both these class of drugs require a little amount of insulin available. At least 30% of insulin should be made available so that these two class of drugs can perform their action. If there is no insulin, means these both class of drug cannot perform its action. Therefore these two drugs are basically indicated in type 2 diabetes mellitus. In type 1 diabetes mellitus we cannot use these two drugs, because in type 1 diabetes mellitus there is practically no beta cells and there is zero insulin present. Okay, so this is the mechanism of action of these two drugs, and we have completed the second class of drug. Next, jumping to the third class of the drug, that is the drugs that retard carbohydrate absorption, and here we have got alpha-glucosidase inhibitors. Okay, so the name only says retard carbohydrate absorption. So carbohydrate absorption, where it takes place, basically these are the class of drugs that will mainly act on your gastrointestinal tract. Okay, and these drugs will inhibit the alpha-glucosidase. So what is the role of this alpha-glucosidase? We'll check out now. So first of all, they retard absorption, means these are the drugs that basically act in your gastrointestinal tract, on your gut. Okay, so in your gut only there will reside an enzyme, and the name of that enzyme is, yes, your this enzyme only, alpha glucosidase. Alpha glucosidase. So this alpha glucosidase enzyme, it is mainly present on the brush border of your intestine, and this enzyme, it is mainly involved in the last step of glucose digestion, like lactase, maltase, galactase. These all are kind of alpha glucosides, which are mainly involved in the last step of the digestion of glucose. So what these enzymes what these drugs are doing, acarbose, meglitol, voglipose, these all drugs are inhibiting the alpha glucosidase. Okay, so what basically we have to do is we need to inhibit this enzyme alpha glucosidase. We need to inhibit this enzyme. Now when we are inhibiting this enzyme, means in our gut this lactose, maltose, galactose and all the other carbohydrate will be present in our gut. And you know, when in our gut these carbohydrates are present, then what will be synthesized? Yes, from our gut ingredients are being synthesized. Ingredients like GLP-1, it has been synthesized, it has been released. Okay, so it is the response of this inhibition of alpha glucosidase. Okay, so whenever we are inhibiting this enzyme, so a carbohydrate, it will be present intact without unmetabolized carbohydrates like lactose, maltose, galactose, all will be present in our gut, and in response to this ingredient will be released. And you know what this released ingredient will do? Yes, these released ingredients such as GLP-1, it will interact with its receptor, that is incretin receptor, and it will cause insulin release. Okay, so this is the mechanism of action of this alpha glucosidase inhibitor. So these are the class of drug that basically retard the carbohydrate absorption. When carbohydrate absorption is inhibited, means from the gluts ingredients are being released, and this ingredient will cause the release of the insulin. Okay, so the examples of this class of drug are acarbose, meglitol and voglibose. So moving to our last fourth class of drug, where we have written miscellaneous drugs. So here also we have got two subclasses. First one is sodium glucose co-transporter 2 inhibitor, and second one is dopamine D2 agonist. So we shall check out first of all this one, sodium glucose co-transporter 2 inhibitor. Sodium glucose co-transporter 2 inhibitor, that is SGLT2 inhibitor, and the example is dapagliflozin and canagliflozin. Okay, so two drugs we have. So we shall check out where exactly this transporter is present and what will happen when we inhibit this transporter. So for this you need to know about the nephron, which is present in our kidneys. So we have got glomerulus, the Bowman's capsule, which is followed by your proximal convoluted tubule, Henle, and lastly the distal convoluted tubule, which is then eventually mixing up in your collecting ducts, isn't it? Okay. Now, where exactly is this transporter SGLT2 is present means it is basically present in your proximal tubules. SGLT2. S is for sodium, GL is for glucose, and T is for transporter. So basically this is a sodium glucose co-transporter, you can say. And what kind of transportation this will do means, nearby to this proximal tubule will be your blood vessels. So whatever the glomerulus has been filtering, the Bowman's capsule is filtering whatever glucose, electrolytes, amino acids, whatever are been there. So what this transporter will do, it will take up sodium along with glucose, and it will cause reabsorption of this sodium and glucose back into your blood circulation. So this is the role of this transporter. Now what we are doing basically over here, we are inhibiting this transporter. Okay, we are inhibiting this transporter. So whatever sodium and glucose were supposed to get reabsorbed by this transporter, and when we are inhibiting this transporter means this sodium as well as glucose will be it will be imprisoned over here only, into this nephron, into this tubule only. And what we actually want, we want to reduce the glucose. So this glucose, it won't be reabsorbed, and it will be secreted, it will be excreted out via the urine. So this is the simple mechanism of action of this SGLT2 transporter inhibitors. So what we are doing, we are inhibiting the transporter so that the glucose is unable to get reabsorbed back into the blood circulation. See, we have got various transporter for glucose, but among those the most efficient one is the SGLT2 transporter. So we are inhibiting this transporter, because of which the glucose is unable to get reabsorbed, and thereby it will getting secreted and excreted out via the urine. So very simple mechanism of action of this class of drug, that is the sodium glucose co-transporter 2 inhibitor. Next, coming to the second class of drug, that is dopamine D2 agonist. Only one drug is there, that is bromocriptine. So if you remember, we have somewhere else we have studied about this bromocriptine, yes, in your anti-Parkinsonian drugs. That is also a kind of dopaminergic D2 receptor agonist, isn't it? So what is the role of this bromocriptine in case of diabetes mellitus means, it is thought that whenever we are consuming this bromocriptine early in the morning, it is thought that this bromocriptine mainly act in your brain. Suppose this is your brain, and suppose this is your hypothalamus. So whenever you are consuming bromocriptine early in the morning means, this bromocriptine, it will mainly act on your hypothalamus, in the hypothalamic dopaminergic control. Dopaminergic control, and it will mainly control the circadian rhythm of hormone release. Circadian rhythm of hormone release. Okay, so whenever we are consuming bromocriptine early in the morning means, it will mainly act on the hypothalamic dopaminergic control, and it will mainly control the circadian rhythm of the hormone release, and therefore as a result of this, what will happen, it will reset it to reduce the insulin resistance. Okay, it will cause a reduction in insulin resistance for various tissues like skeletal muscle and adipose tissue. Means there will be increased insulin sensitivity over here. Okay, so this is a simple mechanism of action of bromocriptine. And bromocriptine, it cannot be used alone. So usually it is given in combination with metformin or any other sulfonylureas. Okay, so this is all about your oral anti-diabetic drugs.